causes that we need to be thinking about. And when I looked it up online, there was a movie that says there's 8 million ways to die. And that may be true, but in trauma, we're actually looking at kind of a very focused, like, amount of injuries, right? So you can have injuries to the head or the spinal cord, kind of the chest or abdomen. You can have extremity injuries, and you can hemorrhage. So that's kind of like a broad definition. But I think it's actually like even a little bit more helpful to kind of think about some of the more detailed things that that can cause cardiac arrest in trauma. And so things that can kill you, more specifically, you can have a catastrophic injury to your brain, right? You can have a very, very serious spinal cord injury. You can have respiratory failure from any number of resulting things from trauma. You can have some type of a cardiopulmonary obstruction, and that's not a term that we use very often. So what do we mean by that? So I'm talking about a pericardial tamponade, which is going to obstruct the ability of the heart to beat well. A tension pneumothorax or hemothorax, that's going to obstruct the ability for the lungs to expand, or some sort of injury directly to the heart where the heart is unable to beat effectively. So say there is a injury to the muscle wall, or some sort of catastrophic tearing or injury to the heart itself. You can have a catastrophic abdominal injury, and there's any number of things that can happen within the abdomen itself, right? You can get bleeding from a solid organ injury. We can have vascular injuries, or we can have injury to the viscus, to the GI viscus. And then just bleeding in general, bleeding both internally and bleeding out externally. And in later stages, infection can be a serious cause. And so when you look of all of these things, when you look this up, at least in an American trauma database, the primary cause of death for the trauma patients was, a large portion of these were traumatic brain injury. So for the sake of fitting things on my slides, I'm using a lot of abbreviations today. Can you not see my slides? Here, I'm seeing what it shows. Is that better?
Yes,
Okay.
better.
Sorry, I think part of the problem is I purchased another display, and I've been using both of them, and I think it's messing it up. So sorry about that. Let's see if did we miss anything. Let me just go through these so you can see them better. These were kind of the specific reasons that you can die from trauma that I could think of. So overall, at least in an American center, um, at least in an American center or multi centers, these were the primary causes. So traumatic brain injury uh, was the leading cause, and secondary to that was bleeding. And you'll see that there, I've put a little asterisk towards the TBI, and that is because they found that of those traumatic brain injuries, a very large portion, 82%, were unsurvivable, which means that not much that we were going to do in the emergency department was going to make much of a difference. So just that's kind of, this doesn't mean that this is everything, but these are a vast majority of things. For secondary causes of death, they found that airway was one of the leading secondary causes. And then a significant portion, 9%, had a pre-existing condition. So they were already just very sick at baseline or had some complex comorbidities, and the trauma just tipped them over the edge. And then 7% was shock of some sort that, usually is hemorrhagic shock, but can be some other type of shock as well. So when we think about, the since the major causes are TBI and bleeding, and secondary causes are airway, this is kind of why we're shifting this paradigm from the ABCDEs, where we think about airway first, to the CABDs is one way to think about it, with the cardiovascular coming second, and major bleeding coming second. Or we can describe it as March, which massive hemorrhage, and then airway, respirations, and the remainder. So just think too of the causes of, or I'm sorry, that bleeding is going to be one of your major things that you need to be looking for. So we oftentimes talk about trauma as being a science of find the bleeding and make it stop. And so keep that kind of front and center. Sorry, I'm having there we go, some technical difficulties here. So how do we know that our trauma patient is very sick and about to die? And that seems like a really, really easy question, but I think it's actually kind of an interesting question. And this is why I kind of wanted to go into it a little bit further. So there's a variety of things that we use, and I just wanted to talk about some of these and make sure everybody's kind of aware of them and see how you guys are using these. So vital signs labs, we can have bedside echo or bedside ultrasound, other types of imaging, and then just using our gestalt, like how does that patient look when we look at them? So let's talk first about kind of vital signs and our exam, because I think it's kind of interesting. So these are some of the things that we can use to identify our very, very sick patients, right? And so the first is very common. We all kind of think about heart rate, respiratory rate, and blood pressure. And so obviously abnormal vital signs can clue us off, but a lot of trauma patients have abnormal vital signs. So that might not, just because they're tachycardic doesn't mean they're sick. And we've all seen patients that have some episodes of hypotension, and that alone isn't always totally predictive. So yes, vital signs are important, but there's some kind of additional details that we can look at from vital signs. Has everybody heard of the pulse pressure? I'm changing this to that. So pulse pressure is, sorry, I'm going to change this immersive gallery speaker. This changed on me, and now all I could see is you guys. So I'm going to try to change it back. So pulse pressure is simply the difference between the sorry, let me try this one more time because it is totally messing up what I can actually see. Pulse pressure is simply the difference between the systolic blood pressure and the diastolic blood pressure. And when we talk about a narrow pulse pressure, that difference is less than 30. So if you think about a normal blood pressure of being 120 over 80, right, that has a pulse pressure of 40, 120 minus 80. So when you start seeing a narrow pulse pressure, it's because the systolic comes down because you're losing blood, but you're starting to see a higher relative diastolic because you have peripheral vasoconstriction. And so a narrow pulse pressure can B, there are some papers that show that it predicts the need for resuscitative thoracotomy and emergent intervention after trauma. So that is one kind of way for us to see if a patient is sick in more detail than simply the vital signs alone. Next, we would think about the shock index, and I think that we've talked about the shock index before. Correct me if I'm wrong. But the shock index is the heart rate over the systolic blood pressure. So when they've studied this, a ratio of 0.9 tends to suggest, means an elevated shock index, and can suggest a high rate of a high possibility of having serious traumatic injury. However, I find 0.9 to be very challenging to remember. And so I think that a ratio of 1 is simply just easier to remember. And so sorry, the the screen just keeps covering up everything that I'm talking about, and it's making things a little bit difficult. But a shock index, so very simply, if your heart rate is higher than your systolic blood pressure, this can be very suggestive that you have a very, very serious traumatic injury. And the shock index, calculated as heart rate divided by systolic blood pressure, has been shown to be a useful predictor of mortality and need for blood transfusion and admission to the ICU. So keep in mind the shock index. Summarized very simply, if you notice that the heart rate is higher than the systolic blood pressure, that can be a sign of a serious traumatic injury. Cap refill, we check cap refill like in sepsis quite a bit, right? But is it a useful predictor in trauma? I'm going to change my sharing here real quick, and I'm going to try to oh, there we go, because it wasn't showing me when people go in there. We'll go back to here. I'm going to try to share one more time. So cap refill, are you guys using cap refill very often in the emergency department for trauma patients? We don't tend to use it a lot in the US, but it has been shown to be associated with mortality, but the sensitivity is low. So it is a possible area that you can use to assess your sick trauma patients. And then same thing for temperature. We don't really think about temperature a lot, but if the patient is hypothermic, that is a bad sign, especially in a place where the ambient temperature is warm, such as Vietnam. So I will say, though, that for all of the literature that supports using these different vital signs to determine how sick our patients are, there is also additional literature that shows that they are less sensitive or less specific. So these are all things that you need to be paying attention to and keeping in mind. They're all useful data points, but no single thing is going to identify all of your sick trauma patients when they come in. So a lot of times our trauma activations will include a systolic blood pressure of 90, and that's a cutoff. And we often see people making very significant decisions based on a single data point. And that's just simply not sufficient. We need to be a little bit more advanced and we need to be a little bit more sophisticated and nuanced than that. So all of these things, you need to kind of take them all into account. But I would encourage you to start thinking about pulse pressure, start thinking about shock index, start thinking and looking at cap refill and seeing if those things together can start giving you some useful prognostic data. So lab work. We oftentimes will, I had a patient today, and I should have put this in the slide, but they came up from the endoscopy suite, and they had perfed the bowel doing a colonoscopy on this young woman, and she came in with a very protruding, rigid abdomen, and we got an x-ray, and it showed a massive amount of free air under the diaphragm, and the patient was intubated. And the surgeons arrived, and the first question the resident asked me was, what was the lactate? And I had no idea because we had just gotten labs. But when you have a patient in front of you that's obviously very sick, something like the lactate isn't going to answer your question for you. So I think sometimes we look for objective data, but what is the literature? What is the science behind some of this? So some of the lab work that we tend to use is hemoglobin. Hemoglobin has gone back and forth in the olden days, they thought that it was predictive and you looked for a low hemoglobin. We know now that your hemoglobin doesn't change that rapidly. But more recently, there are additional studies that maybe suggest that it can be predictive early in trauma. So you can't hang your hat on hemoglobin, but it may be a useful data point early on, especially if it's low early on. Base deficit. Are you guys using base deficit at all in your trauma patients? Do you get this sent with your blood gases? Well, there is a lot of literature around base deficit and lactate. Both can be associated with bad outcomes in trauma, but neither one is going to be so sensitive or specific that it will tell you the answer to whether this patient is about to crash or about to die. So these are all additional, just like the vital signs, these are data points, but you have to use them in combination with everything else. So if you get lactate or if you get a base deficit in your lab work, that can be great, but and pay attention to it. If you have access to it, use it as a data point, but again, it's a single data point. So when we think about ultrasound for our very, very sick trauma patients, we're not spending we don't need to spend a ton of time looking all over the place, looking for specifics, but there are a few things that we can do very rapidly that will give us a lot of information. If they already have been intubated, it can confirm ET tube placement. We can look for lung sliding bilaterally, and we can look for hemothorax at the lung base. We can look for any kinds of heart activity or pericardial fusion with the ultrasound, and a very quick fast exam. I also will sometimes just look quickly if I have a high suspicion for a long bone fracture, sometimes, and I can't wait for x-ray. You can see those very easily. You can just slide down the femur or slide down the humerus and see fractures very easily. And then imaging, a chest x-ray is less sensitive than an ultrasound, so that's not going to really save you. You can maybe see some free air in the abdominal upright. You can see an open book pelvic fracture on your x-ray. CT will often answer the question of the patient's injuries, but it's relatively slow. and it could be risky to send this patient to the CT scanner. And the MRI for a crashing patient is just not going to help you. So a lot of the imaging for a very, very sick crashing patient needs to be done very quickly and judiciously, and you don't want to be ordering a lot of extra imaging that isn't going to help you directly with your patient in front of you. And so that kind of ends up with Gestalt. There's no single thing of these items that's going to identify your very sick patient for you. And so some combination of all of these things and your clinical Gestalt is what you need to be developing as you see these patients and taking all of these factors into account. So this then boils down to what can you do? What can you do about these? What can you actually intervene upon? And so, when we think about TBI, with a lot of that being unsurvivable, there's not a whole lot that you can do as an ER doctor directly. Are any of you guys putting in bolts or drilling skulls for trauma patients, or does neurosurgery do that? In our practice patterns in the US, it's usually neurosurgery who's doing that. Very rare for an ER to place to drill a skull. But bleeding, right? We can think about how we can stop bleeding. And then when we look at these, kind of the same thing. The brain injury, it's basically conservative management on our part. The spinal cord, none of us are going to repair a spinal cord. We're protecting them and getting to a specialist. Respiratory failure, we can intubate and ventilate, right? For cardiopulmonary obstruction, if they have a pericardial tamponade, we can fix that, but that requires a thoracotomy. Tension hemothorax, pneumothorax, that requires just either a finger thoracostomy or a tube thoracostomy. Cardiac dysfunction, to repair the myocardium, that requires a thoracotomy as well. Anything catastrophic in the abdomen itself, that's either going to be fixed by trauma surgery or interventional radiology. Like, there's not a lot that we can do for those patients besides identify what's going on. Hemorrhage, we can fix, and infection, we can help prevent infection. So when you think about it, there's not a ton of actual interventions that we can actually do. So this sometimes is helpful to think about. There's only so many things that I can do to help this patient. A lot of them are incredibly important and they can save a life, but it's not like you have 500 different things that you need to choose from. So achieving hemostasis, getting good vascular access, making sure that their airway and their breathing is protected, decompress any cardiopulmonary obstruction, and then consulting the specialists. So if we kind of like narrow those down, so I have room to put more things on the slide, it's this. And I added transfusion as well. Obviously, if they're bleeding, we need to replace. We need to stop the bleeding and try to replace what is bleeding. So hemostasis, direct focus pressure. The biggest mistake we see for people bleeding out, crashing trauma patients, is people taking a huge pad or a huge bunch of towels or something like that. Oftentimes, find what is actually bleeding, and more often than not, the site of the actual bleeding, unless it's a lot of different oozing, can be corrected with just direct focus pressure, or if it's an extremity, tourniquets. So finding where they are bleeding and stopping it. If it's in the abdomen or in the chest, you have another step to go to, because we can't access the abdomen. Making sure that we have immediate good vascular access, and we've talked about this in the past, but making sure that you have lots of different tools in your tool belt to get vascular access. Because if you don't have vascular access in your crashing trauma patient, you're not going to be able to transfuse them. You're not going to be able to give them medications to settle the airway. You're not going to be able to give them any antibiotics or other adjuncts. So making sure that you are comfortable with lots of different points of vascular access is key. Transfusion, we're not going to go a lot into transfusion here today because I think we have other talks where we talk about that. The current paradigm is 1-to-1-to-1 ratios for blood transfusions, PRBCs, platelets, and plasma. But we're starting to see a lot more. The trend is going back to whole blood. Are any of you at Chorai or UMC or Bakmai doing whole blood transfusions for your trauma patients, or are you doing different blood products? You use whole blood? Okay, the different product. Yeah. That's still the most common because it's harder to store whole blood. It's just more expensive. But we may see a kind of transition overall to using more whole blood, especially in trauma patients or hemorrhagic shock patients. Airway, we're already experts in the airway, and so I don't think we need to talk too much about this. But this is one of the interventions that we can do. The big question is assessing whether a trauma patient, needs to be intubated. And there's lots of different things. The Glasgow Coma Score, this is a whole talk into itself, but the Glasgow Coma Score, we talk about whether, a GCS of 8 means to intubate. And there is not great literature to suggest that that's actually true. I think what this suggests is if their GCS is 8 or less, if they have a low GCS, just a low mental status, that should prompt you to doing a really good examination of the patient and see, are they protecting their airway? Do they have adequate breathing? Because usually sometimes a low GCS can go along with not breathing adequately. But are they breathing adequately? Can they swallow their secretions? Do they have a gag? Are they coughing when things go down their windpipe? And is there a lot of vomit or blood? Or is there pending collapse? Did they get an injury to the neck or any swelling or things that could cause them to lose their airway? So there is not great literature on how to truly assess an airway, but I think it's very important that we understand that it's much more than simply a low GCS. And some of the more recent papers suggest that patients that are intubated for low GCS sometimes have worse outcomes. So it's not always the safe thing to do. But this is a whole entire talk into itself. But be aware that we should be using a kind of more sophisticated assessment of their airway. I shorten this down to decompression. The kind of way to do this, if they're, if the problem is a pneumothorax, then obviously finger or tube thoracotomy. My understanding is that at Chorai, the ER doctors are not doing chest tubes. Is that still the case? And is it different up in Hanoi or at UMC?
Yeah, we don't do the chest tube in the ED. The thoracic surgeon will do it either in the ED or in the operation room.
Okay.
And in some, yeah, in like crushing patients, we can put the needle, decompress by using the needle, and then
Uh-huh.
the thoracic surgeon will proceed with with the chest tube.
Okay. Okay. That's good. And yeah, like for a lot of these things, in every hospital, every place will have different practice patterns. Sometimes this just means you know, consulting the right service to get the thing that needs to be done. Um, for a crashing trauma patient, if you suspect or in cardiac arrest, traumatic cardiac arrest, our practice in the US is that we will usually do bilateral finger thoracostomies. So basically the first part of a chest tube where you've made an incision, you've gotten into the chest cavity, and you just put your finger in, and that just opens, it makes a communication to the outside. So if there's pressure, if there's tension pneumothorax, that will relieve that tension. and that is a very quick procedure and can at least kind of, if tension pneumothorax is the problem, that solves that. Needle decompression is a good second choice if you only have access to that. But there is, when they've done studies, it's not always successful, and it's harder to know if you're in the right place than if you put your finger in there. For the other problems that can cause a like cardiopulmonary obstruction, such as pericardial tamponade or cardiac dysfunction, that would require a thoracotomy. And my understanding is that is also not done in the emergency department in Vietnam, typically by the emergency department doctors. Is that correct? I'm going to go with the assumption that that's the case unless you let me know otherwise. But this can actually save a life. I actually just got a call from my one of my residents in Fresno. I'm now in Salt Lake, but back in California, and he texted me, and about a month ago, just a few weeks ago, they had a patient who arrived at the front door who had been stabbed, and they took him immediately to the trauma bay. They didn't have any warning that the patient was showing up, and he lost pulses right in front of them. So the ED resident, did started the thoracotomy himself. The surgery team showed up by the time he had opened the chest, spread the ribs, and the surgery team showed up in time to help him deliver the heart, meaning open the pericardial sac. And there was injury to the ventricle, and the surgery team sewed it temporarily, took them to the OR, repaired it in the OR, and the very next day the patient was he was still intubated, but he was awake and alert, and with a GCS of 15, he was fully recovered. So the immediate thoracotomy can directly save a life. And so it's a good skill to have. If it's outside of the practice patterns of your place, then you can't obviously do it, but be aware that that is kind of part of the practice pattern in the US. It's very rare overall, and it's rare to have survival from it, but it is kind of part of our practice patterns. And then consultations, just like we talked about. A lot of times it's not us. So identifying the problem and then talking to the right people. And we obviously don't need to go through this. This is usually trauma, neurosurgery, vascular surgery, but IR, and then a lot of the other surgical specialties. So if you identify a crashing patient that has one of those problems that you can't fix directly, getting your specialist service on board as fast as possible is key. So if you can't do chest tubes, for example, and you think the patient has a tension pneumo and you don't have interventional capabilities, you need to talk to the surgery team immediately. Um, so and this is what kind of part of why I changed this talk a little bit, because if you're not doing thoracotomies, then it doesn't make a whole lot of sense to talk a lot about thoracotomies. But the reason we would do the thoracotomies is getting hemostasis if there's a vascular injury within the chest itself, like the pulmonary vasculature, or just direct aortic compression. You can basically put your hand in and push down on the aorta and compress and occlude the aorta. And so even if you have bleeding in your abdomen, there may be a role for a thoracotomy with aortic compression because you're decreasing the blood flow to the bleeding injury in the abdomen. Um, Obviously, once you open the chest, you've relieved any tension from a pneumothorax or a hemothorax. And just like we talked about, pericardial tamponade, once you open the pericardium, then you relieve that tamponade, and then any direct myocardial repair. Um, so the surgeons can obviously do more. They can repair injuries to the airways and things of that nature, but those are the things that we would do in the emergency department in a thoracotomy. And then the other option that is also an aortic occlusion device is Roboa, obviously. Um, do any of you use Roboa in the emergency departments? I don't think I've seen it done, but I haven't been in the department in Chorai. Haven't spent a ton of time there lately. Doesn't sound like anybody does it. So again, like um, I think that there's um, no reason to talk in detail about it, but it is, there's maybe something from the chat. Yeah. Um, so, we can, when I'm out there, if you guys want to talk more about Roboa, or I could send you some information on it, but it is, it's basically you are inserting a line in the femoral arterial system and floating a balloon up the uh, aorta from the femoral artery, and then you inflate the balloon, and it occludes the aorta at some point. There's three different zones: high, basically low, medium, and high. Let's call them. And when they've looked at studies, some of the outcomes are similar to thoracotomy, to resuscitative thoracotomy. I think that there are probably specific patients that this is helpful for and specific patients that it is not, and we haven't yet figured out the optimal patient population for using Roboa. But if you are in a center that does it but doesn't do it often, it oftentimes takes so long. If it takes 10, if you think about somebody who's bleeding out, and if it takes you 10 minutes to place a Roboa balloon, then you've probably missed your window of this being an effective intervention. So let's see, how are we doing for time? I just wanted, these are other topics that we could deep dive on, but I figured I would just kind of ask you. And I know people don't like to talk that much, but I wanted to just open this up for conversation because it's an area of um, of where we can be a little bit more sophisticated with our trauma care for our very sick trauma patients or patients in traumatic arrest. So this is a really good question. The first question, do cardiac compressions, do chest compressions have a role when you have a traumatic arrest? And I'll just kind of frame both arguments here, and I'd like to hear your guys' thoughts. So typically, what will happen if someone has a cardiac arrest, we start chest compressions regardless of what the source is, the thought being we want to keep pumping blood to the brain while we are working on getting the heart started again. And so when we're not sure, even if it's a traumatic injury, we will typically start chest compressions. The counter argument is, well, of the things that we looked at that can cause death in trauma, a lot of it is hemorrhage, right? That was the second leading cause. And so if the problem is hemorrhage and they have not enough blood to circulate, then it's not really a problem of us pushing on the heart, because the problem was that there's no blood to actually circulate. So doing compressions isn't going to pump any more blood to the brain because it's no longer in the vascular system. The other argument is, since we looked at some of the other things that can cause death, if it's a cardiopulmonary obstructive process, if it's pericardial tamponade, if it is a tension pneumothorax, then compressions are also not going to relieve those things. You need to relieve them directly. So there's some people that say that chest compressions do not have a role in traumatic cardiac arrest. And that oftentimes those compressions get in the way. They make it harder to do the treatments that they actually need, such as vascular access, venting the chest, thoracotomy, or some other major intervention. Um, what is if anybody's willing to have an opinion on this or share what is the practice patterns at your hospital, or what are your thoughts given those two kind of counter arguments? No, no direct thoughts. Okay. Well, currently we still do compressions, chest compressions for traumatic cardiac arrest. But the last one that I was a part of, and it doesn't happen very often in Utah, it happens much more frequently in other centers, but it was a skier who came down and hit a tree, and they were doing compressions while the two different people were doing opening the chest with a sharp scalpel blade, right? They're just like venting the chest on either side, and it just makes that procedure very difficult. And I think if I had to choose, I would probably do compressions when there's nothing else going on. But if someone's trying to do a procedure or if someone is intubating or anything else, I would just hold those compressions, which is counter to in a medical arrest and also um, and also might alarm people if you don't have everybody on board with that. So, um, no worries. Good to see you. Thanks, Dr. Dong. Um, so, anyways, those are those things. For some of these other topics, I think we can put like I have a little exercise at the end here that I think might be more interesting than talking through these things, especially since everybody is a little bit shy and we don't speak a whole lot out here. But some of the other kind of these are some of the other topics in traumatic arrest that we talk about. And one, always be aware that of medical mimics. So, you have somebody who has the heart attack and that causes them to get in a motor vehicle accident. So always keep in mind medical mimics, but we're not going to go into that directly. Giving vasopressors in trauma is typically thought of as off limits because the primary source of shock is hemorrhagic. But there are often times where pressors, especially if you are intubating or you're giving pain medicine or something else where you are unmasking their underlying hemodynamic instability, I think that it is okay to use pressors temporarily to bridge you to a place where you can do definitive treatment. So, in order to keep them from crashing, for example, when you intubate them, which is common, then I think using pressors briefly, push dose epinephrine, I think is okay, and it gets you out of arrest. Um, and that kind of goes with the peri-arrest intubation. So those discussions, um, maybe we can design a workshop when we come out there to talk a little bit more about that in depth. But I think that this is just a challenging environment to talk about those. So the last part of this is, oh, let's go back one. So given all of those things that we talked about, I just am going to give you a little scenario. So let's say that there's kind of a multiple car accident right outside the door of your hospital. And we'll see how this works. This is an experiment. It may not work. If you guys aren't able to participate, then this may not work out very well. But I wanted to kind of give you a chance to check this out. So let's say that there's 3 patients and they are brought in immediately. Okay. And all your nurse is able to tell you right off the bat, you have the first patient is a 65-year-old male with head injuries. You have a 33-year-old male with abdominal injuries and a 28-year-old female with chest injuries. and you ask for vital signs, and here are the vital signs for all of these patients. And so when we talk about your 6-6 trauma patient and talked about some of the vital sign findings that we had before, if anybody wants to look at these and tell me which of these patients are you most concerned about, and why, just for this information. Like if they just give you this and they say, which patient do you want to go see first? Who would you choose? I'll give you a second, but this is going to require, okay, people like to chat better. Okay, this is good. Patient 3, everybody wants to see patient 3 first. And why is that? And this is fine. If you guys are comfortable typing, then we can do this by typing. So why do you think that patient 3 is grabbing your attention the most? I'm just going to wait to move on until somebody puts in their reasoning in the chat, and that'll give us something to talk about. I know sometimes it's easier to type than it is to speak. And I'll tell you right off the bat, there are literally no wrong answers here. But everybody seems to agree that they're most concerned about patient 3. Let's see. Tachycardia, yeah, tachycardia and relative hypotension. So yeah, the shock index, exactly. So the heart rate compared to the blood pressure is concerning. And that's one of the most easy things to see, right? We can recognize that pretty readily, and I think we're all pretty familiar with that. If you look at patient number 2, if you look at their pulse pressure, he has a tachycardia as well. His heart rate is greater than his systolic blood pressure, so he actually has a positive shock index as well. And he has a narrow pulse pressure, right? It's something that it doesn't jump out at us as much, right? But it's worth noting that his pulse pressure, the difference, 100 minus 78 is less than 30. So that might be concerning. And then if we look at the patient with the head injury, he has a very
Recording stopped. Recording in progress.
What happened there? Did I lose you? Did I lose you there for a second? Am I back? Can you still see my slides?
Not.
Okay. I'm not sure what happened there, but let me see what's going on here. Sorry about that. Today is